Where is my message thing that I can send stuff out?
In the chat.
Yeah, where's the chat? Oh, there's the chat down there. I see it. I see it. Got it.
Well, good morning, everyone. My name is Robert Hersey. Happy Friday to each of you. And on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Comorbidity, Understanding and Helping People with Substance Use and Co-Occurring Mental Health Conditions. This webinar is being made available through a collaboration of the Florida Department of Children and Families and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been disabled. If you have questions, please send them to the presenter and myself, the host, FATA Webinars, by using the chat panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio at any point during today's presentation, there are a few options to try using the communicate menu. One of these options is on the screen now, and all options are posted at the top of the chat panel as well. After ensuring your volume, both on your computer and speakers, if applicable, is not lowered, you may click communicate menu, then click the audio connection panel, click disconnect, go back into the audio connection panel, and click call in using computer and follow the instructions. If you continue to experience poor audio through your computer, try using the I will call in option under the communicate menu. The access code and event password are on your screen and at the top of the chat panel. You must be connected to the audio of this presentation and also view it on screen to receive a certificate of attendance or CEUs. We are unable to verify attendance if you are not connected to WebEx via your computer or mobile device. Therefore, audio-only attendees will not be eligible for a certificate of attendance or CEUs. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording and PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on your screen. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FATA website. You will first need to register or sign into your account to complete the evaluation. Please ensure that your name and your email address match what you provided WebEx when you registered for today's webinar. Information you provide FATA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the entire webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close at the end of the day on Wednesday, December 20th. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors the arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar. We encourage you to complete the survey as soon as possible. If you experience technical difficulties accessing the survey, please fill out a contact form at www.fata.org or email training@floridabha.org before the evaluation closes. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenter and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, the Florida Alcohol and Drug Abuse Association, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. Our presenter today is Dr. Bruce Liese. Dr. Liese presented our last webinar, Anxiety and Addictions. He is a professor of family medicine, community health, and psychiatry at the University of Kansas Medical Center and clinical director at the Coffrin Logan Center for Addiction Research and Treatment at the University of Kansas. He is a fellow in 3 American Psychological Association divisions, past president of APA Division 50, and an APA Council representative. He has taught more than 100 courses and workshops on addictions, psychotherapy, and evidence-based practice, and supervised hundreds of psychotherapy trainees. Dr. Liese has more than 75 publications. He is on the editorial boards of 3 APA journals, and he has co-authored 3 texts on addictions. Dr. Liese is the recipient of numerous awards from the APA for his service and contributions. In addition to these ongoing activities, Dr. Liese continues to see approximately 25 patients per week. And now I would like to welcome our presenter, Dr. Liese. Dr. Liese, you are now the presenter. I will turn it over to you.
Thank you. Good morning. Good morning. Good morning, everybody. It's so nice to open up my chat and see, I don't see faces, but I see a lot of smiling good mornings. So it is so nice to be back here. I was here just a month ago, as Robert just said, and you were all so kind. Your comments were so nice. I feel like I'm back with old friends. So, last time when I was here, I did present on one type of comorbidity, which was anxiety and addictions. So I wondered, would this be repetitious? Would you guys be bored? And as I prepared this webinar, it became really apparent to me that there was so much more that needed to be covered. So it's great to be back here to I can't see you, I can imagine you, but it's also great to be back here to continue what I think was a really great start. If there is time, I understand that I would be able to do a role play. And so I would love for some of you, or all of you at least, to consider whether or not you'd be willing to be on screen with me and do a role play. It's a small chance, but if it occurs, these always go well. So it would be really nice to do that. So anyway, let's get started. Oh, and by the way, I welcome questions in the chat, but please be aware they come in so quickly that I often can't see them. So I'm counting on the staff that's helping me here to point out anything that I miss. And also, I noticed after we were done last time that there were some questions left in the chat that I never addressed. So hold me to it. I would be delighted to answer questions. And jump in even in the middle with a question. If I'm not prepared to answer it at the moment, I will come back to it. And again, that'll be with the help of staff. So again, good morning, welcome. I wish I could see your smiling faces, but the delightful greetings I'm reading make me smile. So I am, I'm clicking on let's just see. Okay, there we go. So today's learning objectives are on the marketing or advertising or information material I assume you received already. We only have 2 hours, so we're going to try to accomplish at least three main tasks. I would like for you by the end of this to be able to talk about the biological, in very brief, by the way, but more the psychological and maybe even some social processes that could account for the existence of comorbid conditions. So that'd be number one. Number two, I really do hope to share with you at least my approach to conceptualizing people with comorbid conditions and explain why case conceptualization is so important. And also, with time permitting, I'll talk about the structure of sessions, and with any extra time, maybe even do a tiny role play. It'll be tough, but I will do my best. I hope that this is familiar right here territory, this slide. This is just a snapshot, a screen capture shot of cannabis use disorder from the Diagnostic and Statistical Manual of Mental Disorders, DSM-5. And I put it up here from the start, not because I think you're not familiar with it, but as you look at this list of diagnostic criteria, when people have a substance use disorder, when you look at the list of 11 things that could go wrong when you get addicted to or dependent on or misuse a substance that is potentially addictive, when you look at the criteria, it's amazing that not everybody has another mental health condition. The need to take some more and more of something. Number one, cannabis at larger amounts over a longer period of time. Just imagine that something you do, you just have to keep doing more and more of. And you just have this persistent desire to keep it up. And you start spending more time with it than anything else. And you feel these cravings all the time. And then you fail to fulfill major role obligations. I hope it's obvious that I'm picking one at a time, and I'm up to 5. I don't need to read them all. 8, recurrent cannabis use in situations where it's physically hazardous. As I went through this list, I chose to put this slide up and also a behavioral disorder, gambling disorder, because again, the demands of an addiction are so great and they pull you so far from the life that you probably want to live when you have an addiction that, again, it's amazing to me that there isn't 100% correspondence between comorbid problems, depression, anxiety, bipolar illness, which is more of a physiological mental health problem. But so I thought I'd start out with my own, and perhaps yours too, surprise that the correspondence between these addictive behaviors and other mental health problems aren't like 100%. We might understand this process more if instead of looking at DSM criteria, we look at, and I presented this last time, and I will always present these 6 components of addictions when I talk about addiction, because they help even more to understand comorbidity. And I'm going to define comorbidity in a moment. And I'm also going to go through a very, very helpful schema for understanding comorbid conditions. But first, let's look at these addictions where in DSM you see 11 criteria. Let's look at them. Let's look at the 6 core components. Again, like in DSM, salience means importance. Imagine being, for those who have never been and have to imagine it, imagine doing something that's harmful to you that becomes so important and it dominates your life, your thoughts, feelings, and behaviors so much that it starts to overshadow everything else. That is, as far as I'm concerned, that is fertile ground for a mental health problem. Mood modification, that's almost self-explanatory. Most psychiatric, psychological problems involve mood disruption or feeling bad, feeling discomfort, feeling bored, feeling anxious. So it should be no surprise to anyone that an addictive behavior exists to some extent, to a large extent, to modify a person's mood. And it could be relief from discomfort or boredom or anxiety. It could be the term I'm sure you are so familiar with. It could be that it's self-medication. That's 2A. Or 2B, it could be celebratory. You just don't feel that happiness or that rush or that energy without the addictive behavior. So salience, how important it is, mood modification. It's an instant change from what you felt before to what you feel now. And then tolerance, needing more for the same effect. Um, it just, these set, again, I'm being redundant, but it's so important. These components uh, do a nice job of explaining to some extent why people use, if it helps with mood, why they get stuck continuing to use, and then why it causes additional problems. If you withdraw when you try to stop something, it's pretty anxiety provoking when you want to stop and you can't. Conflict, almost every coexisting psychological, psychiatric condition involves impairment, and addictions only make impairment worse, and then relapse. Trying to make something better and continuing to go back to it. So I hope this provides some fertile ground for thinking about uh, just the logic. But let's talk about what the science, the scientists, the National Institute on Drug Abuse says about comorbidity. The definition is interesting. You know, the obvious thing about comorbidity is that it's two or more disorders in the same person. But the less obvious part that I think is valuable to think about, and this is right from the reference at the bottom, if you want to see the reference that probably is most straightforward and most oriented towards kind of a consumer and not just a science paper, the reference I have in black at the bottom, it involves an interaction that affects the course and prognosis. What does that mean? It means that when you have a mental health condition and you start to use, it's not just an additive effect. It can be easily multiplicative. And of course, that makes recovery more difficult. So this is Captain Obvious, but high comorbidity rates between substance use disorders and mental health problems include problems like generalized anxiety, panic disorder, post-traumatic stress disorder, depression, bipolar, on and on and on and on and on. So, here's a little overview of comorbidity, and I'd love to go through this this obvious stuff quickly and get to the juicy stuff. So, more than 60. Here's just some data that's of interest, and it's interesting because I really expect to see the numbers to be higher, because as was mentioned earlier, I see 25. I actually see 25 patients at the medical center a week, 25 to 30, and then I run an addiction recovery group in the community for free, and we have this Wednesday we had 30 people in that. So I'll see up to 50 people a week by myself. This isn't assigning students or colleagues to it, but I'm just surprised based on my clinical experience that the numbers aren't higher. So 60% of adolescents in substance use disorder programs meet criteria for a mental health diagnosis, according to the research. Patients in treatment for non-prescription painkillers, 43%, and 1 in 4 people with serious mental illness have a substance use disorder, defined as mental, behavioral, or emotional disorder that causes serious functional impairment and limits major life activities. I work with people experiencing homelessness, and 1 in 4 just seems incredibly low, but whatever criteria continually are used for these surveys must be pretty conservative, because there are days when I think I'm seeing 4 out of 4 people who have serious mental illness who are also using. Here's a little chart that's provided, and I think this chart is interesting because when people report that they have serious mental illness, the blue line, it's up over 25%, like I just said, 1 1/4. When people say, I have a substance use problem and I need help, fewer people also have serious mental illness. That I can understand in a heartbeat, because I treat people with addictions ranging from behavioral addictions, which include over binge eating, overeating, using food as a drug, using sex and pornography as a drug, and they don't all have serious mental illness. So these two lines do make sense to me in that the people was, I don't assume everyone with substance use disorder has a serious mental illness. I see a lot of people who are what you're familiar with as high functioning people with addiction. So just for the scientific integrity of the talk, those are numbers that I think are worth thinking about. And again, the surprise for me is that the numbers aren't higher. But this is where everything starts to get a little more interesting. There are times when I'll see somebody and I'll find out their background and I'll think, well, there's so many things that went wrong in your life when you were growing up that there were common risk factors for both. And of course, you would have both problems, addiction and other mental health condition. But there are people who have mental health problems. That was number one. Number two, there are people who have mental health problems that actually, I mean, no surprise, contribute to substance use and addiction. If you think back to my list of 6 impacts or 6 core processes in addiction, the second one is mood modification. So for many people, the suffering of a mental health condition that's painful, anxiety, depression, as I said, all of the mental health conditions, who wouldn't look for a solution in every corner? And when substance use does the trick, so to speak, of course, there's going to be comorbidity. And then substance use itself, of course, can be the reason why people have mental health problems. I went through that list, and as I said, it should be no surprise that people who use over and over again, particularly adolescents, young people and younger, when you start using while your brain is still developing, there is a very good chance that the impairment you experience can lead to such significant deficits that you will develop a mental illness. And here the term kindling is used. So that's a little bit on understanding. Okay, everybody loves really complex, big, giant algorithms, don't they? What I've done here is to give you the big picture, and then I've broken it down in the next few slides. But if you haven't heard of the addiction syndrome, I am very, very happy to be the one to bring it to your attention. While the reference you see at the bottom, Dr. Howard Schaefer and colleagues, is 2004, that was just the seedling, and a lot of research has been done on the addiction syndrome. I want to make it very clear, and what am I going to do with these concepts? I'm going to explain, and this is the first objective. I'm going to explain the biopsychosocial phenomenon of comorbidity using this model, which is a well-accepted model in the world of research on addictions. Don't worry about reading the little words. Again, I'm going to bring it to your attention in larger font in a moment. But you do see the big picture, the addiction syndrome on the left. Distal antecedents means what happens to you early in life. Now, if you're my age, early in life is still in your 20s and 30s. So that doesn't mean when you're born. It means along the way before you reach where you are today, but distant enough that it's become, whatever it is that happened has become a habit. Premorbid is the regular use of a substance, and then the expressions, manifestations, and sequela, the third column, I'll talk about. So I'm going to talk about all these. Again, my aim here is to show through the addiction syndrome in very plain terms that it makes sense that people would have comorbid conditions. But it's a little bit more elegant than just saying, oh, they're self-medicating, or, oh, they use so much that they have this mental health condition. So I'm taking something that's so apparently obvious, comorbid conditions, and trying to look at it from a higher level. So again, I'm showing you the first slide. Left-hand column, I'm going to show you first. Distal antecedents. And biopsychosocial. You see in the upper left-hand box, neurobiological elements. These include the elements that contribute to a person's addiction and or mental health condition even before they're born. These are genetic risks. These are neurobiological system risks. These, if you have a family history of bipolar illness, schizophrenia, addiction, even to tobacco um, or alcohol, but even to tobacco, there is a genetic risk. It's more likely that you have both a mental health condition and an addiction, just unfortunately, because of your genes. That's why it's so important to do a family history when you're working with people with addictions or mental health problems, and especially comorbid problems. So the top left box are the neurobiological elements that contribute in the distal antecedents. The box below it directly, not the vulnerability, but the psychosocial elements. It's really what your world looked like as in your past. Again, if you're my age, that goes up into your 20s, could be your 30s. I've had people say to me, I was fine until my experience in Iraq. And those, if you witness war or trauma in your late teens, your 20s, early 20s, your brain still isn't fully developed. And so distal doesn't mean just ACEs, adverse childhood experiences. It means anything that may have contributed back then. So again, the first objective is be able to describe the biopsychosocial underpinnings. Here you go. You have your bio in the top square, psychosocial in the square under it. And what does that do? That creates an underlying vulnerability, the box to the right. If yes, and you'll see the middle column in a moment, if yes, you're at risk for an addiction. And then you look at the bottom boxes moving up. If you're exposed to certain objects or activities and you interact with them, look at the arrows, and there is an immediate consequence resulting in a shift with drugs in particular, you not only have the underlying biopsychosocial risk, but also the environment has exposed you to your addiction of choice. People do juggle their addictions. Many people start, with cigarettes, or they start with cannabis, or they start with alcohol, because there's so much exposure, particularly in high school. I've had patients when they're juggling their addictions who don't even know about gambling until they're older adults and they've quit everything else. And what happens? The exposure to them, perhaps in their 20s, destroys their lives in their 30s or 40s or in their 20s. So I'm going to go back for a second. That's the left-hand column. The next column's easy. The next column is the premorbid addiction syndrome. That's just where you keep doing it, and the repetition of the substance use causes desirable subjective shifts. And that's where the actual dependence starts to occur. And then here are some of the expressions, manifestations, and sequela. Now, it's called the addiction syndrome because you see in the lower boxes where it says biological cluster, natural history, psychological cluster, all addictions, whether you're talking about gambling or online gaming or drinking too much alcohol, all of the addictions tend to have in common or shared, so that we can understand addictions as one syndrome. All of them involve some biological cluster, which means like tolerance or withdrawal or neuroanatomical changes. Us humans change when we start to engage in addictive behaviors. Now I'm showing you this, and as you think about the shared manifestations for all addictions, look at this list. Who wouldn't have problematic mental health conditions as a result of these manifestations, or even as, if we looked back at the full diagram, even as distal antecedents. So when you become addicted to something, there's a biological cluster, there's a natural history. The natural history is you start using and it's fun, or you experience relief, or you get to do things you feel more courageous to do, and everything is cool. Even if it's smoking cigarettes or gambling, it's like, oh, this is fun. But the natural history is that graph that you can imagine in your head where it just gets more and more and more. And that's the tolerance part. Psychological cluster, so many people, as you know, as this talk is all about, so many people who keep using start to develop psychological problems, or it could be that they were there before. Treatment non-specificity means cognitive behavioral therapies and some other therapies, as well as pharmacotherapy, they aren't specifically aimed at one addiction. Generally, like cognitive behavioral therapy, it's skills development. So pharmacotherapy, in most cases, it's reducing urges and cravings, like naltrexone. The social cluster, you start to find yourself with doing things that you wouldn't do if it weren't for your addiction, or if it weren't for your, coexisting mental health problem. And then object substitution. That's where you can go from addiction to addiction. So these are shared. If you haven't heard of the addiction syndrome, the purpose of the addiction syndrome is to demonstrate there are profound commonalities between addictions. One of them is the comorbidity that you see in the box below. That's a big fat box of comorbidity. Now, the outcome of drinking on the top, the unique outcomes of drinking, gambling, smoking, and IV use, they look different. You don't get liver cirrhosis you don't get liver disease from the mere activity of gambling from your home. Just like you don't go into gambling debt when you're sitting and drinking at a bar and not gambling. So these are unique, and they fool people into thinking, oh, I have just this disorder, or I have just this addictive disorder, when in fact, you have elements of all addictions if you have one addiction, as you can see from the bottom. So the addiction syndrome starts to lay out ideas right before our eyes, and I'll go back again, that really do explain the biopsychosocial underpinnings and commonalities between comorbid conditions. And, I'm a clinician. I just told you I see 25, 30 patients at the medical center, individually and in a group, where the medical center charges and collects insurance. And this has been for 40 years. And then I go do literally for 40 years at that job, same job. And then I go volunteer, and I've been doing that for close to a decade. I go volunteer, and I see more people with mental health problems. And the addiction syndrome just makes so much sense to me. And what else does it do for me? It helps me with, if I ever have a lapse in compassion or a lapse in patience where I don't feel patient with people with coexisting problems. Remember what I said earlier is that the use of drugs to treat a mental health problem, or a mental health problem that leads to drug use for self-medication, interacts, and it makes life more miserable, and it makes it difficult to change. And you see the complexity there. And I didn't want to neglect the complexity, and there's no better way to show it than this. The idea of an addictive personality was popular decades ago, but it was studied and studied and studied, and there is no such thing as an addictive personality. I think the closest thing is this addiction syndrome. And again, purpose of showing this to you is to help you think really clearly about how coexisting disorders actually occur. So we wouldn't want to have a presentation where we don't talk about real people and real cases. Naturally, I would never present actual patients. The interesting thing is I wanted to do a video of a real patient that I've seen, and when I discovered that my presentation today would be video recorded, I absolutely cannot. I can't show a tape of a real patient, even though they've consented, because people can unconsent. They can withdraw their consent. And so Scott and Kathy don't exist as real people. They are just a composite of people I've seen. So I can describe Scott and Kathy all I want, and there will be no Scott and Kathy to come back and withdraw their consent. But boy, I have seen this over and over and over again, and it's really instructive. So rather than read every word of it, I will just tell you about Scott and Kathy. Scott contacted me and said, I need psychotherapy. And I said, great, tell me more. And he said, my wife and I have been getting along. She said, I need to see a psychologist. I need to see somebody who can help me. And I hear you treat both mental health problems and addictions. And I said, yep, I do that. And he said, if I don't stop using, my wife is going to divorce me. I said, okay, well, we wouldn't want that. Let's sit down and start to do let's get to know each other. So I started to see Scott, and because my background is also in marriage and family psychology, I quickly was able to get Kathy involved. She was very eager to get help also. So what's interesting, picture Scott and Kathy in their 40s, and they have they have a family, they have kids, and so there's a lot at stake in their recovery. I say their recovery. Now I'll share that Kathy, just like Scott, has been in recovery for years. Both of them have been in recovery for really serious polysubstance use. Kathy had many near-death experiences and multiple sexual assaults while she was using. Never before that. They both started when they were in their teens, and they both found Narcotics Anonymous to be extremely helpful. That's where they met as friends, and they got very, very close. And then, sure enough, they got married. But what's interesting here, that's background. Bringing this to today, Scott was interesting. He was, I never doubted his honesty because he told me some pretty terrible war stories. But he also described numerous psychological and physical problems and symptoms and relapses. So Kathy never relapsed. So these two have been together for 15 years. They've been in recovery for about 5, and she just never used again. And so again, I'm seeing her, but he has complaints like he can't go out. He can't go out for very long in public because he can't use a public bathroom. He sleeps sometimes all day. He can't be with his kids because he fears that he's going to do them harm. Again, this is not a real couple. This is a composite. But he's got a mountain of psychological and physical. He aches all over. As it turns out, he's seen dozens of mental health care workers over the course of his lifetime. Kathy has not. But as I talk to Kathy, I think, boy, your only problem now that you are not using, your only problem is that you're in a terrible marriage. And I looked and I looked and I looked, and Kathy, I could find no evidence of a comorbid condition. She doesn't have a history of depression except when she was using. She doesn't have a history of anxiety. She has a job that she's had since she began recovery. She's good at it. She parents well. They take the kids, she takes the kids to do all kinds of normal kid stuff. She goes to all meetings, all her NA meetings, all her school meetings. She has, by some standards, recovered. I The only thing she comes to me for is, what do I do when he does this? What do I do when he does that? And everyone listening now knows you don't just say to people, well, why don't you divorce him? She doesn't want to divorce him because she's hoping that the work we're doing together will fix him. And as it turns out, one day I was thinking about Scott and I thought, what is his problem besides depression and anxiety? What are his mental health problems add up to? And I one day read to him all the symptoms of borderline personality disorder, which I will do on a regular basis. And all but two, he said yes to with enthusiasm. And I said, you have borderline personality disorder. You might be surprised at his response. He said, why hasn't anyone ever told me that? And I said, I don't know. I can't talk for them. And he said to me, is there a cure? And I said, you're in it. We are going to work on every symptom one by one. And we are going to also work on relapse prevention. And, I have confidence that the therapy works, or I wouldn't do this for 40 years. Well, he's been working his butt off and getting better and better all the time, as evidenced by Kathy's reports. But it is such a complex therapy with him. It's difficult seeing her because she doesn't have a mental health problem that we're zeroing in on. It's how do you cope in a terrible marriage, because he's so uninvolved and so afraid of his own kids. But he's working very hard. His attitude about being diagnosed with borderline personality disorder, his reaction is, why didn't they tell me this before so I could work on it? He reads books about borderline personality, self-help books, and he's applying everything he's learning. And because we're working on both simultaneously, he's getting better. Now, better does not mean good, but better from both of their perspectives is 100% better. So I like this case because I've seen many, many couples for addictions. Sometimes one has never had one. Sometimes one has, both have had them. And sometimes, well, many couples don't come to me for addiction. But these two did. And the stark contrast between the person that has the mental health problems and the one that doesn't is so instructive. Kathy it was so much easier for her to stop using than it was for him. So I told you a long story. I sure hope that helps you think about in real clear terms the complexity, but also the complexity when two people are married, both have addictions, both are in recovery, and one has a mental health problem. I just told you work with him has been good. I have enjoyed it. He has been collaborative. He does his homework. His wife acknowledges that he does his homework. And so all is good. But how did we get there? And this is something I spoke about in the anxiety webinar last month. And why wouldn't I? If treatment, as I present it, works, why would I present something new here? I hope those of you who were here last time just find this as a good kind of review. Treatment involves content and process. What does that mean? What it means is I got to sit in the room with Kathy and Scott. I have to sit in the room with Kathy and Scott and experience them firsthand as a human being. That's the process. I'm starting with the right side. So how I help them, the dynamics between us is not the same as what I try to help with. With him, I had to really think about the process of how and when do I announce that I think you have borderline personality? How and when do I explain comorbidity? how and when do I challenge him when she says, I think he might have used, and he doesn't, he doesn't report it. So that's the human process of the patient and me. And the content is what they say they want to work on. And, when I get in trouble and don't know what to do next, the good kind of trouble, because I want to help the patient and I'm not sure where we are, I will often look at if the content, if he says, I want to start being with my kids and not be afraid I'm going to hurt him or whatever, that's the content. But if I see something in his process, like right now, he looks really depressed, or right now, he looks really strung out, I've got to start focusing on the process. So that to me is the most intriguing thing about all psychotherapies, is that they all have, and counseling, all talk therapy. So, I started to talk here about what the content is of therapy. It's what needs to be changed. And the content areas are obvious. People come to by the way, even though I presented this last month, I actually changed the slides to correspond with the fact that today we're not talking about just anxiety. We're talking about, we are talking about comorbid, all comorbid conditions. So I'm going to go through this slide that I've changed a little bit more carefully. So so what that comorbid conditions exacerbate each other? So what that a lot of people who have an addiction also have a mental health problem? So what if there aren't implications for treatment? And there are strong implications for treatment when you're treating people with comorbid conditions. Look at that left-hand column. Of course, they're coming in to change their behaviors if it's an addiction, but emotion regulation is so relevant. How do you change your behaviors when your new behaviors don't help you with your lousy emotions on the left-hand side there? So while you're treating people with comorbid conditions, it is a juggling act, and it is important to realize and remember and remind yourself. By the way, I'm going to go back to my comment about surprise at how many conditions, how low the overlap is between conditions. Again, I'm jumping off this slide. Stick with me here for a moment. I'm surprised about the comorbid conditions of mental health problems and addictions, or other mental health conditions. But you know what? I'm also interested in just the sheer terror, anxiety, depression people feel that's subclinical, the subclinical threshold. When you help someone stop an addictive behavior, they're not going to feel good. They are not going to be thrilled. They may have a moment of excitement, or a week of excitement, or a month of excitement. And maybe in some rare events, somebody who quits something is just happy-go-lucky after that, and they don't feel bad. But even with people that don't have diagnosable comorbid conditions, pay attention to how they regulate their emotions, because if they have an addiction, they've become dependent on changing their feelings with medications. And then the next one down that left-hand column is distress tolerance. Think about the distress you feel when you're trying to change a salient behavior in your life, any salient behavior. Imagine the distress you feel if you forget your wallet, your cell phone, you can't start your car in the morning, and you're dependent on your car to get to work, and you've never used public transportation in your life. Or you always use public transportation and your bus doesn't show up and you can't be late for work. Tolerating distress, these are content areas. When you're counseling people or doing therapy, these are content areas that really demand our attention as helpers. So those both columns are important. When you have a comorbid condition, every problem is solved with use of a substance, and new problem-solving skills are needed. And lower left-hand side again, boy, it sucks to have these problems separately, and together it's even worse. And self-compassion is very important. So These are content areas: improve judgment, interpersonal skills, communication skills. Interpersonal skills might be just knowing when somebody uh, needs your love, your care, your attention. Communication skills are the actual behaviors you engage in when you're with them. People who started using and have comorbid conditions are, when they're young, when they start using, for example, in adolescence, where would they have learned all this? You know, when we get to the last slide, sneak preview, spoiler alert, when we get to the last slide, I'm going to say, and I'll say it now, and this way it will be, again, a summary and not just a new announcement. The therapist, the counselor, the helper, the case manager's skills really need to include patience. We need to be patient. We need to engage in distress tolerance and regulate our emotions when we work with people who have comorbid conditions, because suffering doesn't have a silver bullet, and there's no quick fix. But you're sitting there feeling stuff. The patient is feeling stuff, the client, and it may be stuff that's threatening to you. It may be stuff that yanks your heartstrings. It may be stuff that makes you tense because you can't believe this story. You don't know if you should even be hearing it. You don't know if you should be hospitalizing somebody when they start saying, I can't go on like this. When you hear the phrase, I can't go on like this, you were trained to like jump in and say, do you mean you're going to kill yourself? Not literally those words, but sometimes I can't live like this means, hey, I'm going to change. I'm not going to do this thing that's destroying my life anymore. So process is so delicate. It's paying attention to these subtle verbal and nonverbal things that are coming from the patient, and also dealing with your own process, how you feel. And again, because addictions and comorbid conditions together are so challenging, they really do test the clinician's ability to deal with process. So what do you do to make the process work? One thing is you pay attention to how structured the session is. For some people who have never been listened to, structure may require a period of really just listening well, allowing them to ramble so you can get a sense of who they are and what matters to them, but then gradually increasing structure. For other people who are comfortable with structure, it could be having very, very clear, what are we going to work on today? But what's interesting is structure also involves staying organized as a clinician, you in your head, thinking to yourself, where are we right now? What are we doing here? What are we doing right now? Are we making progress? Collaboration is the alliance where you do what you can to be trusted by the patient and valued as a helper, but also that you have the same goals. That's where the word collaboration comes in, or at least pretty similar goals. I have never done a group, an addictions group. And again, I almost never miss a Wednesday night addictions group. And we do them hybrid. So this past week, I had 15 people from all over the country and 15 people in the room with me. I've never done a group like that where everybody has abstinence as their goal. And 3 people in our group this past week had what they called sex addiction. 3 people had binge eating disorder. So what are the goals there? You have to allow the client, the patient, to decide on those. And that's a process, just like structuring is a process. Conceptualization is the most important thing. I put it in the middle because it's the peak of the mountain. And I just always like it right there. I've been emphasizing these 5 components for almost 40 years now. So I've always left case conceptualization in the middle because, you know what, structure and collaboration are important, but after I talk about them, now I can say you wouldn't know how to structure or collaborate without a good case conceptualization. So once you get your conceptualization down, you're structured, you're collaborating, psychoeducation. If people aren't learning from you, they're probably not benefiting. What are people doing in 12-step programs, AA, NA, GA, EA, etc., OA? They learn. They learn about the 12 steps. They learn about forgiveness. They learn about patience. They learn about risky behaviors. So all of the help people get when they're leaving addictive behaviors or getting better with their coexisting conditions, it's an educational process. You're learning new stuff you didn't know, and there are lots of techniques for doing that. And I expect I'll get to some today that are relevant to comorbid conditions. Now, my favorite baby is, like I said, the middle one is case conceptualization. Let me look at the clock. It is, oh, we're doing so well on time. I've only been talking for 50 minutes, 50, and that gives us a little over an hour left. I would welcome in the chat, let me scroll. I don't see any questions yet. If anyone has questions, pop them in there. I will try to answer them before I go to case conceptualization. It's a nice way to give you all a break from my voice. So I'm going to sit for a moment, 10, 15 seconds, see if you have some questions or feedback or comments in the chat. I'm glad you asked. Are you able to share this presentation? Because it may be somebody who didn't know that there's a link to all the slides, and this will also be is also being recorded. Robert, this is where you jump in and feel free to interrupt. And yep, we don't need to click on that. So glad you asked. I'm so glad I stopped. All right. What were your thoughts on okay, let me see if I can tackle these. What were your thoughts on the addiction personality versus addiction syndrome again? Good question. Well, first of all, nobody ever really defined the addictive personality. It never had a definition. It's just, I jumped from one addiction to the other. So there was never any kind of reliable. I could ask 10 people. You ever hear? I could ask 10 scientists, and I could ask 10. I'm just reading the note under. Thanks, Christopher. I could ask 10 scientists, 10 people with addictions, and 10 clinicians, what is the addiction personality? And get 30 different answers. But as you can see from the slide on the addiction syndrome, it is very, very clearly spelled out. And if you were to spend the $200 it costs for the LaPlante, the Schaefer and LaPlante APA 2-volume set on the addiction syndrome, there are mountains of research on each of those different parts of the model. So what I would say is the addiction personality, we could make believe if we want the idea of the addiction personality, the idea of it was kind of like that was like the fetus for the grown-up addiction syndrome. You know, when we were talking about the addiction personality back in the day, we all kind of knew that there was something to it, but the addiction syndrome really spells it out. Let's see, blah, blah, blah. Thank you. Any recent updates, research on genetic components of addiction? I will tell you that the research on the genetic components addiction is so good already that there is really no question on. I am not here to advertise that I have a new text with Dr. Aaron Beck on, and this just popped into my head on this stuff, but we just published a text last year, available through Guilford Press, that I'm really proud of, and we do cover genetics and addiction, and it's very brief because there's so much agreement that if you look at all the research, I don't recall seeing a single study that said, no, we don't see any relationship. When people have addiction in their family, the soft way of saying it, as the way we put it in the book, is it accounts for about 50% of all of the world's addiction. So I have patients who have never, ever, ever I've been able to identify a person that even smoked in their family. And so they say, well, it couldn't be genetic for me. And I say, tell me more about they never smoked. And they say, well, everyone in our family was a teetotaler and smoking wasn't allowed. Well, that doesn't count if you're doing it for religious reasons. You don't know. You could have a very strong genetic component, or it could be that grandpa had such a terrible addiction that no one knew about, that alcohol and drugs were totally taboo. So, but when you look at the really good research, so here's what we know. What we know, going back to the to one of the slides earlier, we know that when you have family history of mental health problems, with it's 50% with schizophrenia. If you have a parent or sibling, if you have two children, it's like 100% chance that one of them would have it. Not 100, but very high. With addiction, because people juggle addictions, we can't like identify one addiction like smoking. Oh, that's 30%, and alcohol, that's 50%, and heroin, that's 22%. But when there's been addiction in your family, there is a strong chance. Some studies found much higher than 50%, some studies found lower. These include twin studies and studies like that where people were separated at birth and they didn't even know each other and didn't have the same parents, and they still had a higher likelihood of addictions than other people. So, and there's no one addiction gene, there never will be. And why is there no one addiction gene? One of the reasons there's no one addiction gene is because, there's so many on the left-hand side, there's so many different pathways to addiction. It could be that your neurobiological elements are non-existent, but you grew up in conditions in your neighborhood, in your social world, where I, for one, have no family history of anyone who ever used alcohol or drugs or smoked, did it for a brief time, did it lightly, stopped when it became more expensive to buy cigarettes. But I grew up in a disadvantaged world, and everyone around me was using. And I had the good fortune of not being at genetic risk. So anything I experimented with just didn't seem like it was great, like worth keeping up or doing more of. So my answer to you is there is no one gene. Your mother and father can drink until it kills them, and it might be that they have no genetic link. They may have met as drinking buddies just for fun and never stopped. They never got out of the habit of drinking every night. It may be that nobody in your family has been using for years, but you're at risk because of your biology. So there's a lot of pathways. Thank you for your kind comments. I felt so welcomed in the last webinar. I was excited about seeing you all again. I wish I actually saw your faces. So, opinion of disease model. There is no model that I would reject. Rejecting a model of addiction, unless I heard some kind of absolute absurd model, like you get it from watching cartoons. People need to look at the slide we're on. People need to conceptualize their problems in a way that's useful to them. And clinicians need to go with the patient's needs. If you came to me from, for example, the 12-step program, and what got you sober and a lot and kept you alive was saying, I have a disease, I can never drink again, it would be malpractice for me to say, well, it's not a disease. Uh, it, it it's what it's important to conceptualize it. You know what? It's been called a spiritual malady. If you get help from calling your addiction a spiritual malady, and your solution is that you gain a greater sense of what matters to you in this world, then a spiritual malady was a good way to conceptualize it. So, wonderful questions. First one on genetic components, I think, was the first one. Let's see, appreciate the ongoing success. Okay. Second one was on disease model. So, very good. Good questions, important questions. That was 10 minutes. We better get back on track. Again, the case conceptualization, you say nice things about me, right? You say this is great information, thankful, blah, blah, blah. I love that, appreciate it. It makes me want to come back every week and do this with you. But I'll tell you what keeps me going is my love of the case conceptualization. What is the case conceptualization? It's when you collect relevant information in an iterative fashion. That means you never stop. And the more you learn, the more you still need to learn about a person. It's not one and done. And that's why I have some resistance to a treatment plan, because, you won't find out about terrible trauma from some people until you've seen them 10 times. And then all of a sudden, the treatment plan needs to be changed dramatically. So I like the idea of thinking about a treatment plan, but I don't like the idea of saying, I know what it is and this is what we're going to do. And when it's done, the person will be cured. So it's iterative. It goes on and on. And it is the identification of A, the problems, and B, the change targets. What do you need to change to be better? And with comorbid conditions, you better believe that the problems are going to be more vast than somebody who says, I hear you help people quit smoking. I have a great life. I am not depressed, not anxious. I just started smoking and I can't seem to stop. And when they stop, they don't get depressed. They just get itchy, itchy in air quotes. And they just want to know what are the best techniques. So, the targets when it's a comorbid condition, as I just said, and I'll repeat it, you have to have an open mind to it. Could be the targets are the content that I talked about earlier. It's ongoing, like I said, iterative, it's ever evolving, but it's hypothesis formulation. So, my hypothesis with Scott, who isn't really named Scott, nor does he fit any of the things I just described, but he's hypothetical. But my hypothesis for him was, I think you have borderline personality disorder. When I tested it, he said, I do. Thank you. What do I do now? And I said, read about it and let's do what we need to do in therapy so that you don't have all these symptoms. But the hypotheses have to be formulated as part of the case conceptualization process, because you don't read minds. You don't know what's really going on inside. It's strongly influenced by your theoretical model, your professional and personal life experiences. I don't happen to have a history of addiction myself, so I wasn't influenced by any personal program, which kept me 100% open-minded to all of them. And it kept me grateful to how helpful all of them are. But if I had been in one and that was life-saving to me, I would have been at risk for thinking that's the only one. And if I had been raised by people who were rigid and stubborn and closed-minded, and I was a psychologist, I might think my theoretical is the only right one, or the disease model is the only right one, or cognitive. So these are all the things that influence your case conceptualization. It's not just you, it's the patient. Everything in your case conceptualization will help you with treatment. And you got to really pay attention because things will change and you got to stay organized. So not only does therapy involve looking for content and process as you work with a person. I can tell, by the way, by the clock, we won't be able to do role playing, but I'm going to keep talking and keep welcoming questions. So think about questions and I'll answer them. as we get to the end, but we still have we still have 50 minutes. So you don't just want to know what people think. You want to know how they think. Are they rigid? Do they rely on automatic thinking for everything, or do they think things out? The content is what they think, and the processes are how they think. So their ability to focus and whether they're even psychologically minded. Oh my gosh, I have a patient right now with a comorbid condition, and I have never seen a more difficult case of somebody with obsessive compulsive disorder with no compulsive patterns, but everything has to be perfect. And this person I'm seeing just doesn't think in abstractions, doesn't think about. I could say in couples therapy, your wife is crying and you're still talking. Did you notice she's crying? And he'll look at her and say, yeah, I see she's crying. And he'll keep talking. He's not a mean guy. He's just not at all psychologically minded. He has OCD, mostly obsessions and he's ruminating in the session and he can't stop the rumination. And, it's very hard teaching him some of the skills he's going to need to quit. Sometimes those people quit and they still have all their problems, what some people call, not my favorite term, but some people call them dry drunks, people who don't change how they live in the world with their comorbid illness after they stop using. But anyway, so I like reminding, and again, you may recognize these 6 boxes from the last time we met, if you were here last time. But it's pretty clear that people's addictions and other mental health behaviors, mental health conditions, it's pretty obvious that it's always a vicious cycle. Let's just forget about what's in the squares now, but even agoraphobia, you feel the anxiety, it's terrible. You're supposed to go out and do something. You stay at home, you turn on Netflix, you feel better. You go into the kitchen, you get something to eat, you sit down, you relax, and you feel even better. And there's no bad consequence. So what do you do next time you feel anxiety? You sit on the couch, go to the refrigerator, watch Netflix until you believe you can't go out anymore. That's a vicious cycle for example, agoraphobia. Look at this one for addictive behaviors. When people have emotional distress, it's an internal trigger or cue or stimulus. An external trigger is more of a conflict with somebody or failure at a job or a car wreck or a fight with their kids or a microaggression at the gym. So triggers always play a role, but some of them are invisible. And which ones are we most interested in when we talk about comorbid conditions? We're most interested in the internal triggers to addictive behaviors, the emotional distress that people so-called self-medicate. And I have no problem with the term self-medication. It's one of the reasons people get tangled up in addictions. It feels better for a moment or for an hour or for 3 hours or until they wake up in the morning and realize what they did the night before. But a cue or a trigger or a stimulus doesn't trigger everybody. In order to be triggered, you've got to have thoughts. Now, this is so vital. You've got to have thoughts and beliefs that are activated. If I'm not going to smoke a cigarette when I'm tense, the thought never occurred to me. If I don't have the thought, I'm not going to do it. If you don't have, when you are in recovery, the thoughts are more salient as you quit than they will be in 10, 15 years. Some of you were cigarette smokers and are no longer cigarette smokers. Thoughts and beliefs don't get activated after a time for most people that quit smoking. So first box on the left are the triggers. They can be subtle, but they are so often invisible. apparently unknowable without careful scrutiny, mindfulness, deliberation, attentiveness. So once the thoughts and beliefs get activated, that's when the urges and cravings pop up, and that's when people feel an impulse to engage in the behaviors. And it's a physical feeling often. It's like a hunger. And does that just happen because of a cue? I stick a bottle of scotch in front of you, and you start getting urges and cravings. Well, for a lot of people with addictions to alcohol, history of addictions, scotch wasn't even the drink of choice. It could be, it could be that the urges and cravings follow a cue, like seeing somebody on the street who's asking for money, and that reminds you of when you asked for money to buy your drugs. So the urges and cravings that you experience physically, there has to be a certain, gosh, I would really like to do blank. Now you have the opportunity to abstain in the lower right-hand side, which causes that terrible feeling of ambivalence. Yes, no, yes, no. Think about someone with a comorbid condition. They already feel bad. And then it gets exacerbated by ambivalence. Oh my God, I can't decide anything. I'm such a loser. Well, fine. If I'm a loser uh, and I'm just a worthless piece of crap, um, I might as well just use. That's where I give myself permission to lapse. I'm mentally ill, I think. I'm never going to get over this disorder. I'm stigmatized all the time for the way I am. I got nothing to lose. I really have nothing to live for, in fact, with my comorbid condition. That's my permission to use. That turns into a lap. And that's going to trigger more distress. Okay, I used last night. I haven't used in a week. I screwed up. I'm a loser. I suck. I need to go back. Or not even I need to go back. It's not even, it's a flash. The thought can be that automatic. And again, remember the addiction syndrome. This is the addiction syndrome in boxes that I draw to make it a little easier to see. Again, early life experiences. Remember my little, not my, Dr. Schaefer's boxes. It took the whole page up, but the vulnerability box was teeny tiny. Let's just go back real quick. That little underlying vulnerability box there on the upper middle, if yes, well, here you go. This is what the vulnerability is. It's cognitive vulnerabilities. You tend to think, I need a fix. I need to feel better. I need to do better. I can't. I'm just, whatever the cognitions are. So those are vulnerabilities that develop with continued use and with all the concomitants or correlates of mental health problems. The stigma that's external because you have your problem becomes internalized stigma or self-stigma. And those beliefs create a vulnerability because you say, what the heck? Why wouldn't I use? What else do I have? Behaviorally, it becomes compensatory. Instead of learning how to go out in public and have fun and engage and be friendly and be kind and be thoughtful and part of the world, I'm just going to drink first, and I won't have to figure out all that complicated stuff. That's a compensation. And then it becomes habitual. So what I'm doing is I'm expanding that little teeny weeny box. In our work, what we've done is expanded it to explain that, these vulnerabilities are what develops when you use, particularly when you're young. Picture a 16, 15, 14-year-old. How do you date how do you ever date in a healthy way when you need to have a cigarette or have a drink just to calm your nerves when you do something new? Do you have to smoke a cigarette outside where you're meeting somebody and go in and smell like cigarettes? Do you have to have a couple drinks? Do you have to take a hit off a joint? So those are vulnerabilities that you develop when you become addicted. And affectively, it makes your depression, anxiety, anger etc., worse. More exposed you are to these things, like I said earlier, the more likely it is that you will develop this reinforced and problematic pattern. And when you put it together, you have a very clear case conceptualization model for understanding addictions and comorbid conditions. Somebody wisely, smartly earlier said, asked about the genetic components. The genetics might just be, and there is research that shows that people are more likely to have substance use problems when they have a depressed mom. I can't cite that study off the top of my head. That's one I read in graduate school over 40 years ago on the original studies on alcohol, genetics and alcohol. So it's not that they drank, you drank. It's that there were all these different early life experiences. And now that you're in the thick of the addictions, and those red arrows point to how you're more likely to have part of the vulnerability is what the cue becomes or what the trigger becomes if it's internal. And once you start using your addictive behavior, it becomes what you think you must do. So there's your model. What do you do with this model? Very, very simply, there are 10 things that I encourage people to pay attention to and encourage people to actively engage in as you work with people. Develop a case, look at this, case conceptualization worksheet with 10 items for the rest of your career. It's so helpful. And then, after teaching it for decades and doing it for decades, I don't need the sheet. It just pops into my head. What are the primary problems? Well, with somebody with comorbid conditions, it's the addictive behaviors. But the primary problems you've got to realize are depression, anxiety, anger problems, withdrawal, isolation. All of these are part and parcel of comorbid conditions. So do not fall for the question, what do you treat first, the addiction or the mental health problem? Do not fall for that question. The most important question of all is what is necessary today to be helpful to the patient. You should be really disturbed. I'm going to repeat myself. You should be really disturbed by people who claim you've got to be clean and sober before you can start the process of full recovery. From, again, doing the numbers, I've had close to 100,000 interactions over 40 years at 20 to 40 hours a week of doing therapy. And I may have believed that a person has to be clean and sober, to use that phrase, in order to get help from me at the beginning. But I've learned and earned the gray hair and hair loss to prove it, that there are people who, when you pay attention to their other needs as a clinician, they start to get ready to change their addictive behaviors. And what is that called? That's called harm reduction. As you help people change the things they do and the world around them and help them develop skills, they are more responsive, much more responsive to changing their addictive behaviors. Believe me, trust me. I will say to people, if you stop drinking, or if you stop smoking, or if you stop snorting, or if you stop shooting up, we can figure out things and accelerate the treatment. And once in a while, people say, okay, I'll stop. Or they don't say they'll stop, and they come back and go, I haven't used for 4 days. And I say, how do you feel? They say, terrible. And I say, now what can we do, since it's been 4 days, to address some of the other problems you struggle with? You still have your depression, you still have your anxiety. So the primary problem here, as the first thing you do in the case conceptualization, is an opportunity for me to say, don't fall for that nonsense that you have to have stone cold sober people in recovery. Now, do I love the fact that I am so glad. I'm so grateful for inpatient treatment programs and that start people out with abstinence. They help people get off their drugs, or they require that they're not using them. They do urine tests. They test them. I'm all for people stopping completely and getting intensive treatment. But in the real world, if you do good work, you'll find yourself with people that aren't ready to quit. And meeting them where they're at is ever important, especially with comorbid conditions. Again, I would say a third of the people I treat come to me sober because they've had extraordinarily good treatment in inpatient programs. Now, I say a third, but that a third is some of those people in that third I've seen for years and they didn't go for inpatient treatment. Then they went and they got better. And now they're ready to see me. I'm thinking of one person right now who I'm thinking he might turn that corner and go for inpatient treatment, get sober first, and then come out after 28 days of sobriety. And then we'll work on depression and anxiety and relapse prevention. All right, so in the case conceptualization, pay exquisite attention to the primary problems. Don't get distracted by any of them. Learn as much as you can about how each manifests. Learn how addictive behaviors that you're dealing with impact the mental health, and how the mental health problem is being treated, self-medicated with addictive behaviors. That's a tall order, but heck, we all got into this business because we care about this stuff, and it's the order we signed up for. Social and environmental and health and cultural contexts are important. What community does this person come from? What about them is different from who you are and what you need to understand better so that you're culturally competent, so you understand the ever-present impact of their environment when they go home, where they came from before they came to you. How much are they food insecure? Does their culture mandate certain things that you may or may not be familiar with, or is it just customary? That's number two. Number three, and this is, you can just do you can. Oh, I'm going to answer that psychedelic plant medicine treating addiction, because I've had a bunch of patients who now have been involved in that. But make sure I don't lose that question. I want to go through this first. Thank you for that question. Distal antecedents, again, you've got the picture. Now we're talking distal antecedents, proximal antecedents, cognitive process, affective process, behavioral patterns, and readiness to change. Now you have this slide. You don't need for me to go through every one of them, but it's putting this picture together. And you just use that list to kind of draw your notes up. I have had entire programs saying we're just going to adopt that now. I've had trainees who said, well, that's how I'm going to do my intake now, with my supervisor's permission. And then I've had supervisors of students that say, we're all going to use this. It's on the slide. It's in the book I wrote. Primary problems, social, environmental context, cultural context, distal, proximal, cognitive, affective, behavioral. So again, here's the picture. Distal is the top box. Cognitive, affective, right below it. Culture and continue exposure, experimentation, continued engagement is the environmental component. Triggers, internal stimuli. So that'll be a really good friend to you if you do this in a structured fashion. I'm going to respond to the question about psychedelics, plant medicine for treating addiction. I sometimes love the fact that I'm not a physician and that I have no license to prescribe medication. I love it because there is no silver bullet for anything. And everything that's tried everything that's tried is going to help some people. And I'm not a scientist or a practitioner that either has a license to prescribe these things, nor do I have the background to do research on them. If I had a patient who said, I'm going to use these things, who am I to say, well, you're not the one who's going to get the benefit that other people benefit from? I have had now, I've had a bunch of people like that fit the description of the guy Scott that I made up who have tried it. And they go for like, I'm talking ketamine, they go for, and other drugs, psilocybin, they go for like 15 treatments and say they just feel like crap afterwards. They sleep a lot afterwards, no change. And I have people who say, you know what? All it took me was one ketamine treatment. So what do I think? Same thing I think of the disease model. If you tell me you're going to try something that doesn't involve self-harm, harm to others, suicide, or anything, or danger, I've had people, again, I am not I'm not the police. I'm not special forces. I had somebody say to me that he was microdosing, and I said, where do you get it? And he said, on the internet. It's like, well, your mood really does seem better. What was interesting with him microdosing is at some point he came back and I said, are you still microdosing? He said, no. And I said, why not? And he said, because it stopped working. Went back to feeling depressed with microdosing of, I guess it was, I don't remember what it was. Might've been psilocybin. So if you want to pull the opinion, what I've shared with you is I'm not opinionated about disease model, about psychedelics. If you want me to be opinionated about something, just talk to me about case conceptualization. I'm really opinionated that you must do case conceptualization well. Doesn't have to be this way. It doesn't have to be my model, but really get to know all of these things about your patients. I'll be passionate about that. And notice I haven't used any labels like psychodynamic, cognitive behavioral. That's what my passion is, not judging psychedelics, but I like talking about my patients. I would say 1 in 10 people that I know of get some kind of help from those things, and the other 9 don't. But boy, that one person's life is saved. All right. I wish we had a week to talk together, but we now only have 28 minutes left, which is definitely enough for my slides and the rest of my presentation. And your kind remarks about this is helpful make me think I shouldn't just stop with the content so I can role play, because role playing doesn't necessarily provide you with all this content. It's just a chance to visualize. Someday maybe I'll get to see you at a more experiential workshop. Those are really fun. Agenda. Here's the deal. If I don't believe that I can come up with a treatment plan for my patients that lasts from beginning to end, what do I believe? What I believe is that people with addictions and people with depression, anxiety, bipolar illness, schizophrenia, I can go on and on, all different psychotic conditions, ADD. What I believe is that their needs change week to week, month to month, day to day, visit to visit, minute to minute, second to second. I've had patients come in with lukewarm agendas, and then in the middle of a session, they'll start sobbing. And I'll say, what's going on? What are you thinking? And they'll tell me something that they've never talked about before because it was triggered. And you shift the agenda dramatically. And that's what you're working on. Let me talk about the rest of the structure. You don't have to do anything rigidly in life. You do something rigidly, you don't learn anything. But the components you see in front of you, just like the components of a case conceptualization, I have found to be so helpful. I want people who see me to set the agenda. I want them to say, I had a fight with my wife. I hate my parents, but I have to live with them because I have no place else to live because I just quit using and I'm depressed and I can't start working yet. I just don't feel it. So I live with them and I hate them. Well, that's today's agenda. What if next week is I had a little lapse and I'm thinking of using today? If you don't ask people, what do you want to work on? And I like to frame it, what do you like to work on? Now, a bunch of people who have addictions and comorbid conditions don't know what they want to work on because their lives are in disarray. So I definitely ask them, what is your mood? A lot of times their mood determines what we work on. Maybe they are depressed. A lot of people come in angry. I'm on the drive over, traffic sucked. I was on the subway and it was really crowded and somebody kept elbowing me the whole ride. I had a big fight with somebody before I came over. I smoked a joint before I came over, so my mood's good. So, what do you want to work on? What is your mood or how are you feeling? And then bridging. Bridging is vital, 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 vital. Bridging is where you have this case conceptualization of them. They talk about certain things and you say, what do you want to work on? And they tell you, and you bridge back to their progress and what they have, what you're bridging to. Or if they say, I don't know what I want to work on. I started to say earlier, we're still calling this guy Scott. By the way, I have friends with those names, so they were just easiest to remember. I it, it's interesting. Scott would often come in and say, "I don't know what I want to work on. What do you think I should work on?" And what did I do? I went to the bridge. I bridged back to my conceptualization. I said, Scott, there's always a week where you're not as involved with your children as you want to be. There's always a week where you get in trouble with your wife. There's always a week when you don't offer to help at home with anything. There's always a week where you sleep too much. Pick one of those. That's the value of the bridge. Now, the next one, prioritize. There are people who come in with lots and lots of agenda items. Then you have to figure out what's most important, or maybe just two. And then you guide them to discover what their problems are, maybe patterns, and then you can figure out what are you going to do about that one. And I don't know if the functional analysis is next, but I'll show it to you in a minute. But what you do is you facilitate skill development. Skill development is when you're unhappy, what do you do? When you're anxious, what do you do? When you're angry, what do you do? When you want to smoke, what do you do? When you want to drink, what do you do? Where do you go? Where do you get the heck out of? And sometimes the patient's language involves words like hungry, angry, lonely, and tired. I want to work on HALT, hungry, angry, lonely, and tired. Okay, what do you mean? Well, everybody knows that those are the triggers. And I say, let's talk about any one of them. Which one are you most likely to be at risk of? And well, I don't sleep well. By the way, I just heard this Wednesday, somebody who does not sleep. And, so let's look at why you don't sleep. Let's see if there are any skills you are neglecting. And you always want to ask for feedback. You always want to, and hopefully get a bunch of nice people like all of you that says nice things. But you don't just say, how do you feel about our visit today? You say, what are you getting out of our visit today? I want feedback to that. What are you getting out of it? What concrete specific benefits are you getting today? And what are the implications for homework you might do? And if somebody says, oh, it's been the best session ever, you say, what specifically? And what actionable items are there? If the person says, I don't know, I'm not ready to do anything quite yet, you say, okay. Nothing rigid. It just messes things up. I mentioned sometimes clients have a substance prior to coming to session, wondering how you manage this in session. It's interesting. I love that question. I would say that at least a quarter of the time when I do a big group, 15 people in the room, I smell cannabis. What am I going to do? Walk around, smell nobody's suggesting this, but sometimes you just do nothing. a room full of people and somebody smells like cannabis, you can't do a thing. Now, if I have somebody whose eyes are rolling in the back of their head, oh, by the way, with people with addictions, I ask about the mood and the bridge. Part of the bridge is when was your last use? And here's another thing you should not believe. Do not believe the stigmatizers in the world. Do not believe the stigmatizers in the world, those who stigmatize, who say, oh, addicts all lie. Nonsense. You form a good, honest, trusting relationship with people with addictions. They'll tell you exactly what they did. I don't remember the last time I asked somebody a question because I had a theory and it seemed like they were lying to me. When did you last use? Oh, I took 8 off a joint before I came over here. When did you last use? Well, I always do name your sedative. I always do one a couple hours before I come in because I'm so nervous about seeing you. If you see symptoms of impairment, you do your best ethically to hold on to people until you're sure they're safe. And how do you hold on? You say, stick around. I'd love to talk to you more. Or if you have another patient, you say, will you please wait? You know, we're talking about impairment here. But in a world where cannabis is legal and people take a hit before work, and I just am not the drug police. You have to ask questions about how impaired they are and make an ethics decision. Are they safe to leave? Naive clinicians say, well, I'm not going to see you. You smell like weed. Really? Who are they going to see? What are they supposed to sit home and with their depression and anxiety and quit their job and then when all is okay, they'll come and see you? What I'm saying here is it's a delicate situation. There are no right answers. Be wise, be flexible, don't stigmatize, don't overgeneralize that somebody who smells like weed must be really impaired. Some people take a hit to be normal. Some people are around people who smoke and they smell like it and they have taken a hit, and some people are wasted, and you got to really be more interventional in those circumstances. So I don't take a position on legalization because it seems to be doing some really serious damage in a particular state that I won't mention, where my understanding is it's completely decriminalized. Furthermore, I see in other states where it's totally illegal and people who are already minoritized end up punished. The rich people get away with getting high. They go across the border, fill their sacks with cannabis and products, bring them home and have a good time. And the people who are disadvantaged they're the ones who get nailed. So be very careful, very, very careful. So here are the standardized techniques. I've been asked by this group, what topics do you think we should do next? We could do an entire 2 hours on every one of these techniques. And I will tell you that every good psychotherapy, counseling, person-to-person, talk therapy, encounter requires good motivational interviewing skills. Motivational interviewing involves listening, it involves empathizing, it involves conceptualizing people. But here you go, here's what a functional analysis is. And we have time, and we're going to wrap up with a few minutes for questions and stuff. So come up with some questions. Again, each one of these requires a 2-hour session. I appreciate the nice words you said about the beginning. A session on one of these techniques would have to skip all that and go right to this, which would be hard on some people that don't know the foundation that I just presented. That's why I do 2-day workshops. By the way, when people say, where do you do 2-day workshops? I like to go to your workshops. I go where I'm called, different states, different agencies, different schools, universities, and stuff like that. I don't have one favorite at all. And I present at the American Psychological Association conference every year for a 7-hour workshop for those of you who might be interested in that. That's the not-for-profit one I do the most work for. So you notice on the left-hand side of a functional analysis, let's say somebody says, I used and I didn't want to, or I'm using and I want to stop. What you do in a functional analysis, instead of making assumptions, is you say to them, what were the circumstances? What triggered you? What was the cue? What was the situation? What was your context? And there are 3 of them there because they're usually very complex. It's not just fought with my wife, the end. It may be, or fought with my husband, or fought with my kids, or I just started getting depressed. And so I did a little bit of low or whatever. It's usually I was alone. I was depressed. I reached out to several people. They all said no, they're busy. That's 3 bubbles right there. So there are ATs, automatic thoughts that occur when you're pounded with these things. And there are consequences of that automatic thought. And then the consequences produce more thoughts, which produces more consequences and more thoughts and more consequences. The ATC, but a good functional or chain analysis, you can see why it's called a chain, will help you understand their world. What is the clinical outcome you're interested in? Forget about addictions right now. If you're working with somebody and the challenge is they want to go to 12-step meetings, but they don't. They don't go to 12-step meetings despite the fact that they say they want to, or smart recovery meetings. Well, that's an outcome that's a result of, oh, I'm depressed, left-hand side, I'm depressed, I don't feel like doing anything. I haven't put on my street clothes yet today. The automatic thought is I can't go to a meeting. Consequences, you go to the refrigerator, you start cooking at 3 o'clock, the meeting's at 5. You eat it at 3:30 for those who are lucky enough to be cooks, so forth and so on. But you get the whole story. That's what a functional chain analysis does. You're a detective. You're Sherlock Holmes. You're really, really looking for answers in all the right places. The automatic thought record is so vital. This is the one for again, full day workshop for all these, which is not, I'm not advertising for us having one here. They are where they are. Automatic thought record. I wish I could spend an hour, 2 hours, 3 hours showing you how to fill these out. But you ask people, when did you have the relapse? What was your situation? And by the way, I know you have bipolar illness. What were you feeling? How strongly, 0 to 100? What were the automatic thoughts about your addictive behaviors that led you to use? The 4th column. What else could you have thought, and how can you feel better besides using? And you can spend whole sessions with people doing these things, and they're so grateful that you stop everything and you really want to know what led to your use. What could you possibly do different? A lot of clinicians just say, well, you should have done this, or they say to the patient, what could you have done differently? And I could have just gotten up a little earlier, eaten, and then gone to a meeting. Okay, fine, thanks. No, the more deliberate, the more intentional, the more careful, the more thoughtful you are in this process, using something structured like this, the more likely you're going to get good results. Engage in addict. Okay, so I redid the advantages, disadvantages analysis from last time. Why? Along the vertical axis, you have the advantages and disadvantages of using, and along the horizontal axis, you either engage or you don't engage in your addictive behavior. And you deliberately and carefully and thoughtfully and intentionally, and you take 20, 30 minutes to do this. This is for people also when there's a premorbid condition, the drug use is so intertwined with the emotion regulation needs. Well, yeah, when you use upper left-hand corner, you get relief from your distress. You engage, it's an advantage. You do forget your problems after, 10 shots but no, you do forget your problems after doing a pint of Everclear. You do forget your problems, I know. That is an advantage for the moment. It is medicine that makes you feel normal. But then you go to it. Sometimes I'll start there. I always say, where do you want to start to the patient? The disadvantage of quitting is the lower right-hand side. You feel worse before you feel better. You have these painful cravings. You face failure again. You might fail at it. The people you hung out with are gone now, the ones who used with you. So each of these boxes is worth paying 5, 10, 15, 20 minutes for. How do you spend 10 minutes on one of these panes, window panes or boxes? How do you spend 5, 10, 15? You say, what do you mean you're relieved from stress? Tell me more, tell me more, tell me more. Oh, sad, but not sad when you take into account that it's 10 minutes too, and I might be able to answer a question or two. Summary, conclusions. Comorbidity is common. Again, what's a summary? You heard all this. When you have substance use or mental health conditions, there is a higher likelihood that you're going to turn to the other, that the other will become part of your life somehow. A substance use problem is, over time, very likely to give you another problem, another mental health problem. And it could be that you were doing well and now you have nothing left in the world because everybody left you and you don't have a job, and now you have depression. Number one. Number two, having either one greatly increases the likelihood of having the other. We just know that. So that's just a part of the summary. Comorbidity results in more severe. This is important to remember. It is not an additive effect. It's an exponential effect. It's multiplicative and exponential. When you wake up riddled with anxiety, just shaking to your core, and a hit off a joint takes that away, the more you do it, the more you count on the joint and the more severe your anxiety gets because you're not facing your problems. So remember that and be compassionate and let that serve to enhance your compassion as a clinician. The relationships between the two are complex. A meticulous case conceptualization is essential. Specialty treatments tend to treat one disorder or the other. They just do, but not both. A lot of programs say don't come until. Addiction programs say we don't treat people with bipolar illness. Not all of them, of course, many. And people with addiction programs say we don't treat people with schizophrenia. We only treat people or whatever, this serious mental illness you have. And serious mental illness programs say, he drinks a lot. We need to get him sober first. It's just not the way it works in reality. It's more effective to deal with both. Now, these are my off the cuff kind of comments. These are just my thoughts in the moment. Don't let comorbidity overwhelm you. Don't get attached to outcomes. Don't get yourself burned out because you think you can solve all problems in you, and it's slow and very deliberate. Don't make assumptions like you got to fix one before you can fix the other. Keep your sessions structured. Keep yourself focused. It's so easy to ramble all over the place when people's lives are in disorder as they are with comorbid conditions. Ask the patient, what do you want to work on? And try to stick with that for the visit unless something bigger comes up. Conceptualize people, but also share with them. My experience has been when I say, here's your disorder, people say, thank you. 40 years of that. People say, do you think I'm addicted? I tell them whether I think they have a substance use disorder and how serious it is. Value small gains. Don't put all your money on, okay, this is going to fix them. Small gains may lead to life-saving gains. Pay attention to people's strengths. That's what they're going to need for each change they make, and maintain your curiosity. Experience learning as personally vital. Whoa, look at that. Now you have references, and we have 6 minutes left. All right, let me see what oh, thank you for your nice words. I'm going up here. The question is, would pause be a good psychoeducational tool? And being the person recovering, it's not an approach I take. Everything you do as a good clinician should be a hypothesis test. Even I have the hypothesis you would benefit from pause. Now, I can't say I know what pause is. It probably stands for something I absolutely know. You can type it real quick. I thought it was something, and now I'm thinking, no, it's not that. Pause. I'm scrolling. Okay. Oh, post-acute withdrawal syndrome. I know what post-acute withdrawal syndrome is. Oh, now I lost everything's a hypothesis. There have been scientists that say there's no such thing, or there's no evidence for it. If somebody says I have it, and my understanding is that, yeah, it is the idea that the withdrawal itself over an extended period of time is part of the process. So again, be flexible, and understand if something you're trying is not working, it's probably time to try something else. Proper diagnosis for mental health disorder when they're still using substances. One of the reasons I'm a family therapist is because I can get data from other people, like a partner. It's always good when you can see a family and collaboratively, and everyone wants to be there. And part of the question is, how do you handle a situation when you believe a client's been misdiagnosed? I go in, I don't want to know what your diagnoses were for the sake of maintaining that diagnosis. I do want to know what your diagnosis has been because I want to know how other people have perceived you. But oh, so often do I get people. This guy who I named Scott, he said no one ever told him I had borderline. Well, he also did have the other disorders, but it's the borderline that was the foundation. So in a way, he was misdiagnosed. He has anger problems, right? He was angry at all his clinicians, but me, for a while, because he said, if somebody had only told me, I would have been working this hard for a long time. There's a question, can I possibly get a transcript? I understand this is going to be recorded and on demand, and it says it right under there. Good. I hope that answers it. Thank you again for your kind words. Any other questions besides wonderful things that make me want to come back again? We got a moment we got 3 minutes. If I haven't answered a question you asked, give me another version of it. All right. You know what? I was told anyway that staff needs a few minutes at the end to give you some additional instruction. The name of the book is on the bottom of some of the slides. Name of the book is just Cognitive Behavioral Therapy for Addictive Disorders. It's Bruce Liese and Aaron T. Beck. And it's a Guilford book, and it's on Amazon. And all you have to do is type my last name and the word addictive in Google, and it'll come up. We did 3. The last one is the one that really is current. Here's one. I work with seniors in comorbidity with legal pharmaceutical substances. Oh, I run a group on Tuesday nights, and the average age is in the 60s. We do have some people in their 40s and some people in their 70s. And, we don't change much. What do you want to work on? I ask them, what's going wrong? I always ask about substance use and, what does your physician think? What do other people think about your use? I had a guy who was probably my age when I was seeing him. Oh, let me say this to Monica. After 65 years old, not to the moment, but after 65 years old, approximately, I can tell you because I do consume alcohol, one drink has the same effect as two drinks used to. Older people, because our organs are old, my liver's old, I feel the impact of one drink. So it's really important to educate older people like me about how sensitive their bodies are to pharmaceuticals. In fact, geriatricians will tell their patients, people who treat older people, you don't need the dose you used to take. Your body doesn't need as much because the processing, just the way your body processes it. Psychoeducation is really important. I have had just such delightful and what feels like successful interactions with people older than me since since I started this. And again, stigma against minoritized groups, not that anyone here is suggesting this, includes thinking older people, uh, don't change, or you can't teach an old dog new tricks. I have had a much different experience with the things I've shared with you today and people who are older. We are out of time. What a pleasure. Thank you so much. Robert, did you want to jump in and say anything before you say goodbye to these wonderful folks?
Absolutely. Thank you so much, Dr. Liese, for the presentation today. Again, I'm with you. I'm seeing all sorts of wonderful comments in the chat. So thank you so much for your time and your information. Everyone, we have included Dr. Liese's contact information here. So if you think of a question at any point after today's presentation that you'd like to ask him, feel free to send him an email there. I'm also dropping the link to the evaluation in the chat. When I conclude today's webinar, your browser will take you to that same evaluation on our website. So please do not close your browser when it comes up and asks you if you'd like to be redirected. If you want to receive CE credits or a statement of credit, you must complete the evaluation. You will be prompted to sign in or register to complete the evaluation. You can register as a visitor at no cost. You can do so by clicking "Haven't registered yet." You must use the same email address you used when you registered for today's webinar and when you set up your profile in FATA system. This is the only way to connect your attendance and your profile. After you register or sign in, you will be directed onward to the evaluation. You will also get a reminder email later today to complete the evaluation. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. If you need to add or update your license number, you may do so by logging in and clicking edit on the professional information section of your profile. The evaluation will close at the end of the day on December 20th, next Wednesday. If you experience difficulty logging into your account or accessing the survey, please contact our team either by filling out a contact form on our website as shown on the screen, or by sending an email to training@floridabha.org before the evaluation closes. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 business days after the evaluation closes. As a reminder, the recording and materials used in today's webinar will be available on our website within 30 business days. To access the recording in PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. Thank you for participating in today's webinar. We'd also like to recognize and thank the Florida Department of Children and Families for funding today's education. Have a great day, everyone. On behalf of all of us here at FATA, please enjoy your holiday season and have a happy new year. Please hold for the evaluation.